Today, we talk about
All right, let's get her done. A while ago, one of y'all's asked, what are the differences between the functions of a resident versus a fellow? And I can only give you my experience as a GI fellow, but I assume that some of the roles are very similar across many specialties. So, escada. So, let's start with residency. Well, so long story short, you go to medical school, you go to college, you go to medical school, now you're a doctor. And your first job out of medical school, if you go the traditional route, is residency. So in your residency, you choose a specialty, you go there, and if we want to make it specific to me, I did a GI fellowship, but a internal medicine residency. So to do gastroenterology, which is what I do, cardiology, rheumatology, pulmonology, aka lung specialists, nephrology, aka kidney specialists, not neurology. There's a bunch, but a lot of the main ones you would ever consider all fall under subspecialties of internal medicine as a field, as opposed to surgery or OBGYN or psychiatry or whatever. So under that internal medicine umbrella, you have all those fellowships as specialties. But in order to specialize, you got to get the general-ish down. You know what I'm saying? So you got to go from medical school to internal medicine residency, and that's a 3-year residency in the United States. So you arrive as a intern your first year of residency, and then you become a second year resident, and then a senior resident, aka third year resident. And then after you're done with that, you can either go off and become an attending physician in the field of internal medicine, or you can subspecialize and do these fellowships, which is an additional 1 to 2 to 3 years of training, depending on the specialty. So mine was 3 years, so it was 3 years of residency, 3 years of fellowship. So now let's get back to comparing, differing roles, if you will. So my first day, let alone that whole first year as an intern, you're basically the bitch, and I say that with all due respect. But to be more specific, you are the low-tier physician. So you've gone from having zero responsibility as a non-doctor, all of a sudden you have responsibility, but that responsibility is different than as a second year resident, third year fellow, and then finally an attending. So for example, in the ICU is where my first rotation was. My job was to get there at 5, 6 in the morning and round on patients, meaning I would go around and we had, say, a list of 24 patients, and there was 3 of us interns in the ICU at that time. So around 5 in the morning, some earlier, some later, would come in and see, those 24 patients. We would split up amongst ourselves, so 8, 8, and 8. I go see this 8, you go see that 8, you go see that 8, and we're just seeing them, getting all the lab data together, and writing it all down into the note for the day, the progress note, the documentation of that visit from a doctor to this patient for that day. And a lot of that work is just busy work, to be for real about it. You're not really using your brain much. You're really just collecting the information. So you're doing a physical exam. You're asking the patient what happened overnight. You're asking the nurses what happened overnight. You're going to the computer, checking any new images, any new overnight events, any new labs, and you're just basically documenting them in the right slots on the chart. Then rounds start, and just before rounds, the second year or third year resident that's supervising the interns shows up. Some of them are more aggressive and micromanaging style, so they'll show up just around the same time the interns do, if not earlier, if not just a little bit later, and they're also very hands-on. The more hands-off residents, depending on how much they trust their interns to collect the right information, because some interns suck dick, and others are pretty legit. And you have every range in between. So depending on how, quote, good you are / how efficient you are, you can either trust as a senior resident, you can trust them to do their job, or you have to kind of micromanage and kind of be more heavy supervising of them. Grammar triggered. Now, that residence role is to A, make sure those notes are getting done, B, making sure that all those patients are being seen and assessed by these interns, if not by themselves, and next, they have to, basically if anything goes wrong, it's on the resident, not the intern. Now the resident's role is not, because they're not doing all this grunt work, quote unquote, of like actually collecting the data, because physically, especially at our hospital where we still have freaking paper charts, which still blows my mind. But even if you don't have paper charts, if you're the one that's collecting all the data and putting it all together in the note, you are doing a lot of just busy work of like copy paste, copy paste, copy paste. Not literally, but like that's what you're doing, which a scribe could do. But the reason just a scribe can't do it is because you need a doctor to like know which labs to pull from where, what's relevant, what's not, because you don't just like carry over everything. You carry over the quote relevant stuff. So it goes back to what I was saying earlier. The more efficient residents understand what's important and what's not, and you gain this with experience. It's not something you come in the first day and really know. So especially early on, you're going to be a lot slower than later, because in the beginning you're not sure what's relevant or not. So you're writing and carrying over as much information as possible because you don't want to quote miss anything. But the reality is, once you get into a routine, once you've worked with enough attendings and residents and gain enough experience yourself as a doctor, you start to pick up on what's relevant and what's absolutely not relevant. So that makes you a little bit more efficient, knowing what to skip, knowing what to focus on. And then basically the residents' job, because they're not doing all this busy work, is to make sure that those particular things are focused on, because A, they have experience by this point because they're not an intern anymore, and B, because they're not spending as much time like doing all this quote manual labor, they have time to like focus on, okay, what's the big picture here, what's going on with the patient, how do these dots all connect together between the lab results, the imaging results, what the patient is saying, what the nurse has said happened overnight, day, do, day, do, day, do, day. Got it? Good. Now, keep moving up in the ranks, and then basically by the time you become towards the end of your residency, you should start to feel as if you could do this job yourself. The attendings should have reached the point with you now that they trust your judgment, they trust that you know what you're doing, and they should be as hands-free with you as much as possible. Now, some residents are more prepared for that than others, but in general, that's what you should be shooting for, because in a few months, you are going to be doing this by yourself. And you should basically be doing it by yourself at that point anyway, and just knowing that you have backup, aka your attending above you, to run things by if there's the occasional, weird thing going on or something you don't recognize, or a new particular kind of pattern you're noticing with a particular patient or patient clinical presentation that you haven't really had much experience with, so you want to make sure you know what you're doing. So that's what that's for. But basically, once you become an attending, that doesn't really go away, because now if you choose to pursue being an attending from internal medicine and not pursuing a fellowship, you still have the help of your colleagues and your other subspecialty specialists to help you, because you're clearly not going to know everything within 3 years. But that's kind of the general idea. So that's kind of your role in residency. Now, with that said, you also have a lot of other duties, aka in-house call, meaning whenever you're on call, you are in the hospital. You are not taking home call, because things need to get done in residency as an internal medicine resident. What I mean by that is there's a bunch of these paperwork things that need to happen. There's a bunch of these orders that need to happen. There's a bunch of things that need to be assessed in person a lot of the times. So for that, you need to have somebody in-house. You can't do it from home. It'll make a lot more sense once I explain how there's a lot more home call with fellowship, but focusing still on this. So I'm talking about things like, hey, I know it's 8 p.m. and you're on call, but your daytime colleagues forgot to sign the blood transfusion order, so somebody's got to sign for this, so can you come down and sign for it? And of course, it's a paper form and not a online electronic form, so you have to like physically walk over to that floor, find that nurse, find that chart, and like literally just put a signature. It's like, what the fuck, And then, of course, a lot of times it's not that simple. It's just like, hey, so-and-so is supposed to get consent for this procedure tomorrow, but they didn't, so can you come up and get it? And you're like, all right, so then you have to go up and learn the patient from scratch, because you weren't taking care of them during the day. You're just kind of this on-call person that's like putting out fires or like cleaning up other people's mess for the day. And so now you're starting from scratch, getting to know this patient, reviewing their chart, because this is the first time you're about to see them, understanding why they're getting whatever procedure they're planning to be getting, or why they're getting the blood transfusion they're being planned to get. And then going to actually talk to them, making sure they understand everything, and then actually getting the actual consent of the transfusion or the procedure or what have you. So that's, that's something you have to be in-house for. Or, suddenly a patient's vital signs change, or this happens, or they report a bleed. Then you got to go assess that and figure out what exactly is going on. Because it's so shocking to me, but it's so true. How often, like, you'll be told one thing over the phone, but you get there and it's a whole different scenario, or what you read in the chart is totally different from what you're seeing in person. I don't know how that phenomenon is just so common, especially in a field like medicine, but it is what it is. So you got to go, you got to make your assessment as the resident, and as an extension of that, weekends you're on call often. And again, this will depend on which residency you go to, because some residencies are very much larger than others, but then again, some residencies with larger numbers of residents, like I had a class of 16. Some places I've heard have classes of like 30. It's insane. So but also hospital sizes vary. So depending on that, it doesn't mean you're necessarily on call less. It just means the roles may be spread out either too thin or vice versa, or the opposite of that. So with that said, you're finding yourself on call very often when you're on the inpatient service versus when you're on the outpatient electives or whatever, or on vacation. Obviously, you're not going to have those weekends on call, but in general, you're doing so many months as an inpatient covering the hospital. Someone's got to be in the hospital during Saturdays and Sundays, so you end up having 6-day weeks the majority of the weeks as a resident, to the point where it was so rare as a resident to get both days of a weekend off that we called them golden weekends. It was just so rare to get 2 days off in a row as a resident. Now, depending on, I don't want to get too complicated with it, but depending on the specialty, or depending on the rotation, ICU versus regular floor versus outpatient clinic versus elective, depending on the situation, it'll also vary as to your schedules, but not to the point where you'd ever get 2 days off in a row. So, let alone 2 weekend days off in a row. So, for example, in the ICU, you may be working a 24-hour call, but you'll get the next 24 hours off. But that 24 hours off may be on a Monday, maybe on a Wednesday, and you're definitely not getting the following day off. You're back to work. So, hey. So that's one thing, or that's another thing. And that may be enough, but if you have additional questions as to resident roles specifically, ask me in the comment section here, and I'll address them in a follow-up video. Now, going to fellowship. Now, as a GI fellow, I chose to do GI fellowship. Now, as a fellow, there's less of you, so you're on call maybe more often, but now the calls are at home call. So you don't have to be in-house. You don't have to be at the hospital every weekend that you're on call. So you can still plan to do things, but you can't plan to be away. I couldn't plan a trip on a weekend on call and just take calls over the phone, because if something happened where I needed to come in for a procedure, which was often the case anyway, you'd be screwed. And it was almost guaranteed that you would be coming in for at least one procedure, if not multiple, and at least one consult, if not 16 a day. So there's no way you were going to get away with not being around, but you could sleep in your own bed. You could be at home chilling like this. I could be technically on call for GI right now, and they would just page me if anything ever came up. So that was kind of annoying, just because as a resident, even though you're on call, if you know you're on call in-house, you just stay up. You know what I mean? Whereas with GI, it's I'm working every day. I don't technically get a day off on the weekend, but I just hope that I don't get interrupted in the middle of the night, at least, so I can get my rest, so I can come into work relaxed, or there's no emergencies right at 8 in the morning, so that I can sleep in maybe till noon and then go to work, and just kind of calmly get a couple things done, nothing aggressive, and then go back home and just chill. But it's very variable. So your calls as a fellow can be either completely miserable or super chill. I had some weekends in fellowship where I didn't get called in for either the Saturday or the Sunday. Never both, but at one of those days, I think 2 weekends out of the, I don't know what, 50 on-call weekends I had over 3 years, there was 1 or 2 where one of those days I didn't have to come in at all, but it was super rare. But otherwise, you're expected to come in both days and see the new consults and do any urgent procedures, and then deferring all the non-urgent procedures that need to be done for these new consultations for the following week. So that's kind of the role you have there. And then, it's kind of hard to be a little bit more specific and compare the role of a fellow to a resident because it's such a different role, because you're in a specialty, and I can only speak to my specialty, not anyone else's specialty. But anyway, I can at least say for me, like, I'm still writing notes in terms of my consultation notes, but now I'm not, I'm not writing daily progress notes. And my notes can be a lot more focused, even if I am writing daily notes on a particular patient that's very complex, because, it's a very focused specialty. And then, for example, if someone comes in with, say, a pneumonia, that's a bad example. Let's say someone comes in with kidney failure and a GI bleed. Let's say the GI bleed I can take care of within a day or two, so I write my notes in a day or two, and then I'm out. But the resident and the primary care staff, the hospitalist staff, they are still responsible for that patient for not only the GI bleed portion of their stay, but the kidney failure part of their stay. And then let's say, God forbid, something else happens to them, like they fall, they get a brain bleed or a fracture. Now they're here even longer dealing with the orthopedic specialist. But I dipped out within 2 days. My job was done within 2 days. So it's kind of nice to like fix what you're going to fix and just like dip out. But then for the resident, for that patient, they're dealing with multiple problems across multiple specialties, and they're not addressing them directly because they're not the specialist, but they are overseeing everything and writing all the notes and blah, 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 blah. So they still have a lot more involvement there. The other role that the residents fill that I've never filled as a fellow because I was a specialist, and this may vary hospital to hospital or program to program, but in general, GI and most fellowships are a consultation only field, whereas in residency you are the primary care physician. So anytime some bullshit paperwork comes up, or admission paperwork, discharge medical reconciliations, coordinating this with the physical therapy recommendations for the disposition of the patient out to a rehab center versus an assisted living center versus, coordinating care with a particular family member, blah, 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 blah. You're dealing with a lot more like ish as a resident that as a fellow I'm not dealing with, because I'm literally a specialist in a particular field. So once I have addressed that concern of yours, I am out. Like, I am not dealing with your, we don't want to take Nana home to this facility. Can you work out with this facility? Otherwise, we're not going to take her home. And then now I'm dealing with this, or there's a disgruntled boyfriend who says that, I don't know, there's just like all these other social issues that you have to deal with as the primary care doctor that you don't have to deal with as a fellow, let alone, as a specialist. So that's kind of nice. Just in terms of not having to deal with the headache on my end. I'm not saying their situation is a nice situation, it sucks, but it's nice that I don't have to deal with it. I hope that doesn't sound mean. And it's not. Like, I fulfilled that role when that role was required of me, and I did my duties when that was required of me. But who would want those duties if you don't have to have those duties? Does that make sense? So, and that shit will burn you the fuck out over time. So, like, I was in no way trying to make my life about dealing with those kinds of problems on a day-to-day basis. I don't have the stomach for that. If you do, thank you, appreciate you. Honestly, like, thank you. Like, we need people to fill those roles and handle those concerns, but I'm just not of that ilk. I can't do it. The same way I couldn't be a telemarketer or a customer service rep. Like, God bless you guys, but it's not a role I want to fill. Anyway, so other than that, my other role as a fellow was to do procedures and consultations all day and then take call in the evenings sometimes. And then, for example, when you're not working as a resident, you're not working. Like, there is no home call. Whereas, when I was on doing home call as a fellow, I was covering the hospital, the VA hospital as well, and then the entire outpatient service, which is who knows how many thousands of patients who can call at any time with any complaint for any reason. And all those calls get routed to me as the on-call person. So I'd be getting called at 2 a.m. by a patient saying they're nervous about their procedure tomorrow, or I'd get a call about a patient saying, hey, so-and-so is supposed to send me this prescription to my pharmacy, and I'm here now and it's not there. Can you take care of it? And now I have to look through the whole chart to figure out why we're giving them that medication, how much of it, for what reason, why wasn't it ordered? Was it just decided that they changed their mind but they never told the patient? No, I got to tell the patient. It's like, ugh. So there's all these other things you got to deal with at home that you didn't have to deal with as a resident because you did all your work at work, and then when you're home, you're home. Granted, you know, that is part of your role as a fellow. Like when you're on home call, like you are expected to know that this may come up, but it still sucks. Anyway, so I hope that answered your question. I feel like this has gone longer than I wanted to. I wanted this to be like 6 minutes long. How long has it been now? 20 minutes? Oh, God, I need to learn to shut the fuck up. All right, well, I hope this 20 minutes was helpful. Yeah, anyway, so if you guys have any more specific questions, because I'm coming at it from my perspective, and I've never really thought to think about it until I sat down and just like word vomited it all out to you guys. But if something's unclear, or if you have more specific follow-up questions, just leave them in the comment section. I'll answer them at some point. Hope this was helpful. And see you on the next one. We out. Peace.